I just want to say, for a lot of the residents and student learners in the audience, I always like to say, I don't know if you realize the wealth of experience. I mean, you have a lot of nationally and internationally recognized faculty members so far this morning who are really leaders in their field. I mean, we're in Philadelphia, so there's a lot of academic medical centers, so we're all fortunate for that. So the next lecture, and I'm going to introduce Dr. Lundy, is our William DeLong Memorial Lecture. And I think Dr. Lundy will say a word about that. And as the years go by, probably a lot of people don't know who Bill DeLong was. I trained with him. And I think it's fair to say, I think he's certainly in my time and in recent years was involved probably in the training of hundreds of orthopedic residents and fellows in the Philadelphia area. I worked with him obviously at Temple, but he was the chairman at St. Luke's, started the residency program there. He's held multiple leadership positions, and honestly really was just a mentor to me getting my career started, as well as he was to many others. So I really owe a lot to Bill DeLong. He was pretty fit, very active person, triathlete, taking call, and suddenly passed a couple of years ago during the pandemic, and we named this keynote lecture after William DeLong. And so I just want to introduce Doug Lundy, who interestingly is the chairman up at St. Luke's, so has essentially taken Bill DeLong's position. And he comes from Georgia, from Atlanta. He's from Georgia, trained in Georgia. I think he did his fellowship up at Vanderbilt, but he was president of one of the largest orthopedic private practices in the country for many years. He's got a lot of leadership and has held leadership positions at the Academy and the OTA. He writes very regularly in some of the Academy publications. I think we all kind of see his name and picture almost weekly, and we're very fortunate. He's of course up the street now, so we said we got to get you down here to give a keynote lecture, and it's fitting to have him give the Bill DeLong Memorial Lecture. So welcome and thanks for coming.
All right. Thank you, Dr. Raymond. Really do appreciate the invitation to come here. We're going to talk about the three greatest challenges facing orthopedic surgery in the 21st century. As Saqib said, I am a trauma surgeon. It's my passion. However, I do a lot of other stuff too, and I think it's cool to take a different look at different things. So we're going to do this. This is kind of interesting. As he said, and the only reason I put these things up here is because it's a pretty arrogant thing to say that you're going to talk about what's going to happen in the next 100 years. Nobody knows that. I do have an interesting perspective because of a couple positions I've been in. And a lot of people say, why in the world did you leave Atlanta to come up here? And the folks up here say that. I don't understand that. And so I always say to be with you. But the real reason is to work with guys like Dustin Greenhill, who was just here, and Nay Wachuku, Dave Ramsky, Dave Renner, and all the best reason, though, the best reason, no offense, Nay, no offense, guys, but is to work with the residents of St. Luke's. They are amazing. I love working with them, and that was the reason. Real quick on Bill DeLong. So I was on the Committee of Trauma, the American College of Surgeons Committee on Trauma with Bill. I remember walking in Chicago when Bill got the job at St. Luke's. He was going on and on about what a great position it was. I thought, that's interesting. I will never see it because I'm not leaving ATL. And then here we are. But Bill was indeed a great man. A significant amount of what's happened here in Philadelphia and pretty much everything that's happened up in Bethlehem is due to Bill. So we owe him a huge debt of respect, and I'm honored to sit in his seat. So if we're going to talk forward 100 years, let's look back 100 years. So if we're going to do that, how long ago was 100 years? If you start thinking about it, it doesn't seem that much. We see 95-year-olds in clinic. How long ago is 100 years? Let's take a quick look at it. Coolidge was president. That gives you a little perspective on that. Lenin was still alive. He was actually still the president or the chairman of the Soviet committee, of the Communist Committee there. He had his third stroke and was finally knocked out, so Stalin hadn't even had his reign yet within 100 years. Yankee Stadium, for those of y'all who like the Yankees, they beat us every October, but that's fine. Just opened and played their first game. The Hollywood sign first went up 100 years ago. Pancho Villa was assassinated. And this is Frederick Bunting. Frederick Bunting was an orthopedic surgeon who actually won the Nobel Prize that year for the discovery of insulin. And according to my wife, the most important thing that happened 100 years ago was the foundation of Disney Enterprises. So it'd be quite a bit arrogant to talk about this. If you think about what orthopedic organizations were around then, the AOA was only 36 years old. It was founded in 1887, and if you think about it, the AOA founded the AOS 10 years after that, and the AOA founded the American Board of Orthopedic Surgery 11 years after 100 years ago. So 100 years ago seems like a long time ago, but a whole lot has happened within that period, and it would be the epitome of arrogance for me to say what's going to happen in the next 100 years, but we're going to take a chance at it. When I talk about this, I could see that people, basically what this is a talk about change that's incoming and impending on our profession. And the big thing with this to remember to get your hands around is the entire value proposition. If you listen to Kevin Bozick, the president of the AAOS, he will talk on and on and on about the value paradigm in healthcare, which is quality over cost times access. That is the entire thing. So as healthcare changes, if you dig in, you say, I'm going to do orthopedic surgery exactly the way I did in 2023. I am not changing. This is the way I'm going to do this the rest of my career. It's going to be hard for you, and it's not going to go well. But if you continue to adjust to the value proposition over your career, you'll do exceptionally well, and there will always be room for you at the table. And I think that's the big thing with it, especially looking back if you see all that's happened within the last 100 years. The other thing is I did go to the Georgia public school system. I can't count too well, and as I started getting this talk ready for SOCOP, I realized there was actually 4 greatest challenges. Anybody know that picture? Know where that picture came from? Everybody always wants to say it's the Sistine Chapel, which is fascinating, because I don't think George Washington is on the Sistine Chapel. That's the Capitol Dome and the rotunda of the U.S. Capitol. So here's our 4 topics. We're going to talk about private equity, scope of practice, Medicare payment, and AI. So let's talk about private equity. The big thing with private equity is that affects private practice, and private practice affects everybody. When I was Council on Advocacy chair, I would yell at the academic and employed people and say, I don't need to worry about advocacy. It doesn't affect me at all. It's only for the private practice people that own their surgery centers and therapy and magnets and stuff like that. The big thing is that my doctors at St. Luke's get paid what they get paid because of the competition that would be there if they went into private practice. If we paid them only on their E&M and CPT collections, they would get paid a fraction of what they get paid. So what happens in private practice is exceptionally important to all of us and how that goes. I wrote this article in Clinical Orthopedics, A Day in the Office, Is Private Practice Orthopedic Surgery Dead? And the answer is no. So if you look back at the AAOS demographics in 2012, 74% of orthopedic surgeons were in private practice. The Academy does this about every 6 years. 6 years later, in 2018, it had dropped to 61%. But hear that loud and clear. You'll hear people, including very high-level leaders in the AOA, the Academy, and the specialty societies, say how private practice is now a minority, and it's not. It's not, and it's very important what happens over in that realm where I spent the first 6 years of my career doing before I moved up to Bethlehem. The 2023 survey is not out yet, but it's coming soon. I wrote a series of articles in Clinical Orthopedics, and this one was a very trying one. And a lot of these, and it's kind of funny in retrospect, and Dustin was funny. One morning I came in on Monday morning, he goes, I had a Lundy-thon weekend. I'm like, oh my God, what does that mean? He goes, I read everything you wrote. I go, that wouldn't have taken that long. But he says, I read everything in Clinical Orthopedics that you wrote, and I could hear you talking to your partners. I go, yeah, but my partners didn't read, so they didn't hear me talking to them. But what my point was in this article is that the thing that tears apart really good practices is money. It's overhead, it's allocation of patients, and it's how we handle the revenue that comes in. And it's just completely crazy. You'll get very good friends who start screaming at each other, and everything falls apart over something as stupid as money. So we're going to talk about private equity, which is all about money, and I have no problems with private equity. One of the main reasons that I left for surgeons was because I was against private equity acquisition, which they underwent. So how does private equity work? So you have a guy with significant, or a woman, doesn't matter, there's a guy in this situation with significant net worth who is not satisfied with the returns that he or she is getting in the stock market or through other investment vehicles. So they have this pile of cash. They say, what am I going to do with this pile of cash? I'm not making the returns that I want to make. So they talk to an investment banker in private equity and say, Mr. Investment Banker, Miss Investment Banker, I need you to make me more money. So the investment banker says, thank you very much. They collect the money. They get a bunch of other people's money together, and they go out and buy, here are the words, here they are, undervalued companies. Undervalued companies. That's the key. So they get a company that's not performing well. They say, we're going to buy it. We're going to expand on it. I'm going to show you all in a minute how that works. They make a lot more money. They give it back to the original investor, and the investor makes their money. That's private equity. That's capitalism. If you notice my original slide, I have an MBA. I am all about capitalism. This is good. There's nothing wrong with this. But how does it affect surgeons? What happens with that? Well, the key with private equity in surgeons, and I know all about this because I was involved, I was president of a surgeons on the whole private equity acquisition. I can't tell you the hundreds of hours I spent talking to investment bankers. The key with private equity is you take, as a surgeon, we're all partners in the same practice now, you take your future income earnings today. So money in the future is worth more now. We're going to take it out of the future. We're going to pay it to you now. That's how private equity works. And that's what the important thing is. So we all agree we're going to do private equity. We sit down, we analyze our books, we determine something called EBITDA, which is earnings before interest, depreciation, taxes, and amortization. We get that. We go to the private equity company and they say, oh, your EBITDA is 35 million or whatever. We're going to multiply that by a multiplier, somewhere usually between 7 and the highest I heard was 13.5%, 14%. You get that, I'm sorry, 14 multiple, sorry. You get that, and you get this massive payout, and you sell your company. Your baby now belongs to private equity. Don't even talk to me about the corporate practice of medicine. So there you go. So now they owe the money, and this is called the first bite at the apple. And for most of the doctors at that point, you reach nirvana. It had nothing to do with Kurt Cobain and Dave Grohl. So now you're in nirvana. You're sitting on this massive stack of cash. Life is good. We go on, we come back after our long vacation, we went to Ferrari Atlanta and bought a 488. Life is awesome, and then the haircut comes. And you look at your paycheck and it's 30 to 35% less, and you're like, what happened? I'm like, where did you think the private equity money came from? You just sold future income stream, usually 30 to 35%. Yeah, but for how long? To infinity and beyond. It never goes away. They own your company, you now work for them. So you go, yeah, but what about my future revenue? You already got paid that. Now, there is certain times where this works well. If your company, remember I said undervalued, if your company, if your practice has crummy rates, you're not doing well with your insurance carriers, you have excessive overhead and you're poorly managed, you may actually still be flush with where you were before this happened. But if your company is running extremely well and you sell to private equity, they're not going to make you work any better. So you take your cash up front, nothing wrong with that. If you invest it well and you live on less than you make, you'll do okay. Then about 5 to 7 years later, we look at EBITDA again. Hopefully it went up. We figure out the multiple, and you get another payout. And this is called the second bite of the apple. And that's how private equity works. And you rinse and repeat this as many times as possible. So let's talk about what Tupac Shakur said. He said, follow the rules or follow the fools. What is the rules of private equity? Number one, the private equity investor will get their money. Let me repeat that. The private equity investor will get their money. The third time, the private equity investor will get their money. So as long as everything's hunky-dory, you're getting paid, you're seeing patients, life is good, everybody's happy. But the second things get tough, remember rule number one, the private equity investor is going to get their money. They own their company, and if you're not happy, I don't care. I'm getting my money. I'm the private equity investor. The other thing is that you're going to continue to sell the company every 5 to 7 years forever. That's what private equity is about. Always remember rule number one. But there are really good reasons for private equity, and through my work doing this, I ran into people who were going into bankruptcy. Your company's run poorly, you're not working, you're not making money on this. You say, I need help, like Michael Scott, and you could say, I need to sell this. And the private equity investors are smart. They have really powerful MBAs. They can do this. Another one is you can possibly want growth. I'm familiar with other orthopedic practices that say, I need capital. I want to buy surgery centers. I want to buy magnets. I want to buy physical therapy. I want to expand to new locations. This is a fast, easy, quick, good way to get cash to invest in your company and do really cool things with it. And you could be in your late 50s, early 60s saying, you know what, we built this thing up. I don't really care anymore. Let's sell the thing. Let me get a lot of cash out of it, and then I'll go down to Florida and have a good time. So what are the different ways that we do this? Well, the first way that private equity makes money is through consolidation. So what they're going to do is they're going to buy one company, one practice, and they're going to say, we're going to start adding on to this. So Resurgence, when I left Atlanta, when I left as the president of Resurgence, we had 103 orthopedic surgeons in our group. Now they're up to about 200, 180, 200 as they continue to add in to the matrix. So you consolidate other practices. You try to increase collections. You try to get as much money in the door as possible. You try to reduce overhead. You try to cut expenses as much as possible. And then you're going to sell this same platform for 5 to 7 years. Equity is not going to own you any longer than that. They want to own you, get their money up, build it up, get a lot of cash in it, and then dump it. This is very interesting. So if you look at the amount of money that's invested in private equity in healthcare, it goes up year after year. So in the furthest right there, in 2018, there was $100 billion invested in private equity in medical practices across the country. The problem is that we all look at that. We're all smart. We all went to college. We all know this. But exactly how much is $1 billion or $100 billion? So here's $100 right here. So think about this $100 bill here. What would $10,000 in $100 bills look like? Put it in your mind. Okay, that's cool. How much would $1 million in $100 bills look like? Think about it. You got it? Looks like a football. That's $1 million in $100 bills. Okay, let's talk about some real money. Let's get up to 100 million. Now we got to have a pallet to get it around. So we all know what $1 billion would be, right? It'd be 10 of those, right? So that's what $1 billion. But remember, that was $100 billion that private equity had invested into healthcare currently in 2018. So in a minute, we're going to talk about Medicare. Medicare's budget is $1 trillion. So what does $1 trillion in $100 bills look like? Watch the guy in the red shirt. Talking real money there. And 1/10 of that is what the private equity sector has invested in healthcare. I'm going to show you why that's an issue. Why is that? What's important for healthcare? Because if you think about it, when the ultimate goal in healthcare becomes profit and return on investment, where does healthcare go and what is in it for the patients? And there's so many articles coming out now, so many lawsuits coming out now about this and how this goes from there. And you say, well, I'm going into academics, I'm going into hospital employment. This still affects you because what happens in private equity goes there. So KKR acquired a huge amount of health care back in 2018, and last week they filed for Chapter 11 bankruptcy. And how much did they lose in all this? $7 billion were lost in this acquisition. So when other people are putting capital into healthcare, when it's only about the money and that's all they're taking out, it will affect all of us and our ability to practice in the future. That's the issue with private equity in healthcare. This was an interesting white paper that came out there. I thought it was a pretty gutsy thing to say. They said that because of private equity ownership, mortality increased 10%, implying that 20,000 people died as a result of private equity ownership. I was like, wow, you got some guts publishing that one. Okay, I don't think I would have done that. So what's in it for patients? Number one, profits before patients. Decreased access to physicians, decreased access in underserved demographics. What about the poor folks? What about the people in the parts of the city that need health care and can't get it? Too bad, it's about the money. Increased cost, they overcharge for care. I've got a lot of friends who call me and tell me about that. We order unnecessary tests and procedures because it's about the money. And remember, consolidation always, always, always means decreased choice, lower quality, and increased cost. If you want to argue about it, sure, I'll be happy to argue about it. Just go to MBA school, they'll beat it out of you. It always happens. When you consolidate, when you reduce competition, choice goes down, cost goes up, and quality goes down as well. And then lastly, it's the exact opposite direction that the government wants to go in terms of value-based care. So your outcome goes one of two ways. Either everybody's happy, everybody's sitting around happy like that, or when things go south, remember rule number one, the guy gets his money. What's rule number one? Remember, the private equity investor will always, always, always get their money. So if you're thinking about selling a private equity, just keep this in mind. All right. So private equity will either capitalize the system, allowing increased access to high-value care, or it's going to buy out future cash flow, expand the matrix, turn it for a profit, and this is all at the expense of the company. All right, let's shift on to Medicare. Medicare, what's going on with that? All the great things with Medicare payments and how these things go. So when I was counsel and advocacy chair, which I just rolled off of at the last Academy meeting, one of my biggest jobs every year was to deal with Medicare cuts and Medicare cuts to physicians and how that all goes. And this was all supposed to go away with the SGR fix, which came out when MACRA, which was the Medicare Access and Chip Reauthorization Act, came out. And that was supposed to make that go away. And we were never supposed to have to go up to the Capitol and argue for more money for Medicare. Now, if you start thinking about it, it's kind of weird. We're arguing at the Capitol, the legislative branch for Medicare payments. Who controls Medicare? It's the executive branch. President Biden controls it. So why are we on the Capitol talking to the lawmakers when we should be across the street talking to the White House? So when you start thinking about this, you start seeing some pretty crazy quotes and thoughts about healthcare. Well, look at this. I'll read. I know you can read. I'll read it to you anyway. Healthcare bills are too complex, choices are too restrained, and insurance premiums and out-of-pocket costs are climbing faster than wages and tax revenue. Healthcare markets could work more efficiently and Americans could receive more effective, high-value care if we remove and revise certain federal and state regulations and policies that inhibit choice and competition. That makes perfect sense, right? Who said this? What great private market person, leader, said this screaming across the street at the government? Wasn't at all. It was Alex Azar, who was the Secretary of Health and Human Services under Trump. So it was actually the government going, yeah, the system's jacked up. We should do a lot better. Y'all want to go get lunch? We'll do it. Come on, let's go. If you look in the back, you can see Mike Pence in the background there. This was Alex Azar, who was the Secretary of Health and Human Services. That was his quote. So Alex Azar runs HHS, which is under the executive branch. It works for, well, Alex did. He's not anymore. It's now Javier Becerra. Works for President Biden, and he runs HHS. And under that is what's called CMS, or Centers for Medicare and Medicaid Services. So when we look at that, we say, well, exactly what is the problem with Medicare? Why is it that the government is starting to really cut back on Medicare? Why is it that Adam Bruggeman, who took my job, who's currently the chair of the Council on Advocacy for the Academy, why is it that later in the year he will pound your email saying, go talk to Congress and tell them to continue to fund Medicare and increase our payments to that? Why is that? Because the Medicare benefit payments have gone up astronomically. Remember that $1 trillion I showed you? That's the current budget for Medicare. Every year, the government spends $1 trillion in health care. This is going to affect everybody in this room and your ability to practice in the future. But we all know it's due to hospital costs, right? The hospitals are jacking it up. It's their fault. They're the ones doing it. Whoops, not true. The blue line is the stuff that we get paid, the physicians. It's about Part B. Part B has actually gone past Part A. We're the ones. So we have accelerated higher. Now, why is that? How is it that we are now the ones that are causing the damage and the cost to Medicare? It's because every year except for two, either the volume of physician services or the complexity of the services, which is the higher RVU numbers, have increased every single year. And it's a fixed bucket that we continue to pull out of. Then we go back to Congress and go, well, you got to fill the bucket with more because we're doing more and cooler stuff. And a lot of the more and cool stuff that we talk about at these conferences is all part of the catalyst, which is added to this. So we all pat ourselves in the back saying, I'm using the latest, coolest, wildest thing out there, when something a lot less expensive that would take care of the problem just as well might be better. If you look at it as healthcare spend as a percentage of gross domestic product, so what this basically is saying is the economic engine of the country, how much of the economy of the country is going toward healthcare. As you can see, back in 1960, it was only 5%, and it's now over 20%. So 1/5 of the money that's made in the US is then dumped into healthcare spending. And so Kevin Bozick, once again, kept saying this is not sustainable. I'm like, well, it's not really true. Because if the American government wants to keep paying money into healthcare, they want to pay 50% in healthcare, let them do it. What do I care? How does that go with that? Well, if you look across the world, we are way out of whack on that. Every other developed country in the world spends a little bit more than half to way less than half on healthcare. And guess what? Their outcomes are better than ours. So when we start looking at that, we go, what is wrong with the U.S. healthcare system, and how does that go? And why is Medicare important? Because all the private payers follow Medicare's and Medicare's billing and how they pay us. So Blue Cross, Aetna, United, Cigna, they all go off of what happens in Medicare. So we have to pay attention with Medicare on that. Here's the big problem, is that ever since 2000 to 2020, physicians have taken a 29% cut in Medicare payments. You're going, wait a minute, you just showed me that graph going up, but that wasn't adjusted for inflation. When you adjust it for inflation over the last 20 years, physicians have taken a 29% cut in their Medicare payments. So even though Congress is paying us more and more and more and more, we're taking home less and less and less, which gets to be the crisis that we take up to the Capitol. So as we go up to the Capitol and we advocate for it, this is what I would do as advocacy chair. I would get out to the members and the fellows of the Academy, and I would say, please call your member of Congress, send them an email with the stuff in there. We're going to tell you what to say. Please just send it to them. It's so important for it to do that. Because you got stuff like this going on. This was an article recently published in JAOS that pushed my blood pressure right through the roof. Look at what they said in this. Our analysis demonstrates that certain current orthopedic WRVUs do not appropriately compensate for objective measures of the overall complexity as it relates to each procedure. Significant undercompensation in projected RVUs was noted for several high-volume orthopedic procedures, including arthroscopic ACL repair and revision total knee arthroplasty. And we go up to Congress and say, we are the benevolent people helping the poor. You should pay us more. And what does Congress see us like? This is how they see us. I'm sorry, doctor, is that a Porsche keys in your pocket? And we're complaining how poor we are. And all the while, they're going, we know what you guys get paid, and we know what you're doing with it, and you're not helping us out at all. Here's one of the other big things to it. So this article looked at it and said, due to the complexity, ACL should get paid more. How many ACLs are you doing in Medicare patients anyway? Well, here's the big thing. If you look at it, total knee arthroplasty has gotten materially easier over the years. In Atlanta, 95% of our total knees and total hips went home same day. 95%. So they're not even rounding on them in the hospital. So if you went to the total knee surgeons and said, hey, since it's easier, do you want to get paid less? What do you think they're going to say? So this is what Congress sees us like. So when you advocate to Congress, please be very, very careful of the words that come out of your mouth. They do want to hear from us. They do want to hear from us, but our message has to be abundantly clear, and we have to be able to message to them that in order for the system to survive, they've got to maintain Medicare equity and make sure that we go like that. Interestingly, MedPAC, which is part of the Congress as well, is now finally agreed to try to get 50% of physician payments adjusted for inflation, which would be very, very good. And I love this picture. This is fascinating. Anybody know where this is? It looks like an absolute riot. You know what the riot is from? This is fascinating how this even came out. This is Paris when he decided to raise the retirement age. This is what they did. They said they were going to raise the retirement age, and people came out and started burning stuff and rioting in the streets. So it may take something like this for us to get Medicare, get the government to listen to us on Medicare. Hopefully not. Hopefully we'll be able to maintain that going forward. Let's talk about scope of practice. This is another thing that I would often fight, both on the state level in Atlanta and Colorado, where I was before that, and then now when I was on the advocacy chair at the Academy. The American Medical Association, of which I am not a member, released this statement. Look at this. Health and safety of patients is threatened, however, when non-physician healthcare professionals, such as nurse practitioners or PAs, are permitted to perform services that are beyond the boundaries of what they've been educated and clinically trained to do. And I know there's PAs in the audience, and Doug, you just made it real awkward, didn't I? Well, this is El Pico de Orizaba, okay? This is a volcano in Mexico. It's 18,411 feet. When I was in Colorado, I was climbing. I had every intention of climbing that mountain when I was younger. I'm not going to be able to climb it because I'm too old. No, this is a hill I might die on. I am not dying on scope of practice. I hired, I have 40-something PAs up at St. Luke's. I'm going to let every one of those folks work at the very top of their license. So the AMA is wrong. We can't be doing stuff like that. The problem is that the Medicare and hospital treatments have changed, and we need to adjust with them. So let's talk about it. One of the big things that orthopedics yells about is what's going on with podiatry, how does that work with that? Physical therapy has always been an issue with us. Well, there's a lot of states where physical therapists say that orthopedic surgeons should never own physical therapy practices. South Carolina was a big one on that. We fought that like crazy. Radiology says that we shouldn't own MRIs. They say it's a conflict of interest for us to have MRs, and they try to take that away from that. And by the way, the American College of Radiology certifies your MRI. So the very group that you have to get permission from is the one that says you shouldn't have it. And then lastly, remember, this is the flip side of that. I remember earlier on, you ever wonder why there's not a subspecialty certification for trauma? You ever wonder why? We got it for sports medicine, we got it for hand. Why doesn't the American board have a subspecialty certification for trauma? Probably should, don't you think? Well, what happened was the OTA started doing the math on that and went, wait a minute, I see where this is going. Every Friday afternoon, every sports doctor in the city is suddenly going to go, I can't do that closed tibia because I don't have a subspecialty certification in trauma, so can't do it. The OTA said, no way, we don't want to do it. And the problem was orthopedic surgeons quit covering ERs across the country. And so across the matrix, there was a big need for fracture care across the country, and we as a profession weren't covering it. So the general surgeons came up and said, we'll do it. Teach us how to put X-fixes on, teach us how to breed open fractures, we'll take care of it and give it to you all after it settles down. We said, you can't do that, that's scope of practice. And they're like, then do your job and take care of it. We're like, well, okay. So fortunately it worked out, it didn't get to a crisis, but it could have come closer than it did. So why is this such a big deal? What's the big deal with scope of practice? It's like this, it's like death by 1,000 paper cuts. If you give a little bit, before long, you've lost the whole thing. Let me give you some examples. Primary care. How many people, when you go see your primary care doctor, actually see a PA or a nurse practitioner? Well, let me just ask the big question. Do you get that much better care from a primary care doctor than a PA or a nurse practitioner? It's a lot less expensive if you use NPs and PAs. They're a lot easier to make. They don't go to school near as long. They cost less. If it's the same quality of care, why are we paying more as a country? Why? Does it make sense? It's kind of a scary thought, isn't it? A lot of my fraternity brothers went to optometry school. I don't know why, but they did. Some of my best friends are optometrists from back in college. And I remember in Georgia, we were throwing down, we had to side with the ophthalmologist to go against these people from doing certain eyeball things. Why? They're eye doctors. Yeah, they can't operate on the eye, but they can do a lot of the stuff. And they are less expensive and easier to make than ophthalmologists. Anesthesia, they gave it away with the CRNAs, and 16 states have AAs. Georgia was one of them. Matter of fact, CRNAs were a rarity in Atlanta. Most of them were AAs, or anesthesia associates. So you go get your bachelor's degree from Georgia. Once you sober up enough, you go down to Savannah, get your two-year degree, master's degree in anesthesia, and bam, you're doing CRNA work. You're popping it into tracheal tubes. And I'll tell you, when I was in Atlanta and I was working, doing high volume trauma at one of the busiest places in the country, I would much rather have an AA at the top of the table than the CRNAs. The CRNAs were too busy gabbing. The anesthesiologists were too busy gabbing if they weren't checking on their stocks and playing Candy Crush. The AAs were at least paying attention and talking to us. And then how about vascular? Vascular lost everything, right? My brother-in-law just recently had a dissecting AAA. My wife is a former OR nurse, was panicking. I'm like, baby, times have changed. And all she remembers were these big thoracotomies and blood on the ceiling and all that. And so they rushed him up to Greenville, South Carolina, took him in the angio suite, popped the coils in, boom, he was done. Matter of fact, when the guy called me on the phone right after that, my wife was crying. She was completely inconsolable. He called me up and goes, hey, how do you know Scott? I go, well, we were on the board together. Isn't he a great guy? I'm like, how's my brother-in-law? Oh, yeah, oh, he's fine. So, Dad, have you ever come down and gone hog hunting with Scott? I'm like, oh, my God, my wife's looking at me. But my point was is that vascular owned this, and it's just left. Now our radiology's doing that, right? So scope of practice is important, and this is a challenge. And so we have to be careful with scope of practice. But the important thing, once again, is the value paradigm. So at St. Luke's, we have our PAs working, and our CRNAs in our spine and pain division, working at the very top of their license, doing everything that they are capable of doing. We adjust, we do things the right way, we look at things in terms of the value proposition to the community. And as long as we're looking at that, then that finds that really sweet spot for what we do and keeps all of us relevant and all of us content in what we're doing and in our jobs. The last thing I want to talk about is AI. AI, obviously, I'm a little bit older than should be talking about AI. However, I've learned enough about this that it's obviously an extremely disruptive force, especially as you look at it and go from there. This article is in this month's Clinical Orthopedics and Related Research. Look at the authors. So if you don't know who they are, Seth Leopold is the editor for COR. Look at the trail author, Mark Swinkowski, editor-in-chief of JBJS. And if you want to know, I'll just tell you what this article says. It basically says this. This is if you write an article, a manuscript, and submit it to the big journals, and it's AI that actually wrote the article, you're going to be put in purgatory, in the sin bin. You're not going to be able to get out and start writing articles and publishing again. So they're looking hard for saying who's cheating and getting AI to write their articles for them. Just give you that little thought up there if you're thinking, you know, I haven't got time to get this done. I'll just let ChatGPT do it. Probably shouldn't do that. All right, so as we know, AI is much more specific as you get down into machine learning and deep learning. There's a bunch of stuff out there on this, and I'm not an IT guy, but there's a whole lot of interesting things you can learn about this. It's funny, if you look at the 6 industries that are most vulnerable to digital disruption, look at it right there, healthcare. And it's all in the white-collar jobs that it's most affected. When you're Council on Advocacy chair and you're representing the entire political spectrum and healthcare policy spectrum for the AAOS, you need to know what's going on. And the problem is there's really very few, if any, news outlets that are not so biased that all you're listening to is rhetoric and just this garbage the whole time. But I found Politico to be pretty good. They're slightly left of normal or center mass, but it's pretty darn good. I think they're a pretty good one. And they had this thing called Playbook Deep Dive. If you're into podcasts, I encourage you to listen to it. And what they did was they had Representative Jay Obernolte, who is a Republican in the 23rd District of California, on the 10th March edition, which is number 403 of Playbook Deep Dive. And they talked to him about AI. And he said the funny thing is, now if you go up to Capitol Hill and you look at the members of Congress, you know why Medicare is important to them, because they're all over 65. And many of them are over 80, and it's kind of scary. And you're like, does anybody here know how to turn a computer on? So Jay does. Jay was in IT before he went up to Capitol, and he stands up there saying, AI is a big deal, y'all. We need to pay attention to this. So who's it going to affect the most? Lawyers, doctors, and accountants. All white-collar jobs. That's what AI is supposed to be, the biggest thing that's going to be coming down and affecting with us. And he made this big statement on there that was very bold. AI will be better at reading CT scans than humans can. It's an instant result with no errors. I was fascinated. I got up to St. Luke's. I was supposed to go into rounds with the residents. I said, they can start without me. I need to listen to this whole podcast because this was really, really, really good. So I would encourage everybody to look at this. And then I went down and I was talking to the vice chair of radiology at St. Luke's. I'm like, dude, what's your thoughts on AI? How's it going to affect radiology? Because y'all are opening a diagnostic radiology residency. How's that going to affect y'all? What's going to go on with that? He's like, don't worry about it. We're cool. We're fine. I'm like, really? He goes, oh, it's years away from happening. Really? Oh, don't worry about it. It's going to take so long, it's never going to happen. Remember, the Nile is not just a river in Egypt. I think he's completely missing the point. And if I would not be going into diagnostic radiology right now. So here is obviously one of the Apollo missions later on when they had the SUVs running around the moon on there. How many people have actually stood on the moon? Anybody know? There was only 12. Only 12 people ever stood on the moon. How many of them were Russians? Anybody? None. The only people who have ever stood on the moon were the United States, was the US. But anyway, if you think about it, from getting from here, that's the furthest that any human has ever been off the planet, right? So if you think about going all the way there in this LEM, in the Lunar Landing Module, and then coming all the way back, and all the math, y'all have seen Apollo 13, right? And all the stuff responsible to that is in that spacecraft. And this cell phone is 100,000 times more, has more computing power than that LEM. This cell phone has 100,000 times the computing power of that entire LEM. And the radiologists don't think that a machine that's looking at ones and zeros all day long can't see a sarcoma way before they can? I would think that AI is going to disrupt diagnostic radiology very soon in the future. And what are all those radiologists going to do? Are they just going to go, oh, well, shucks, I had a good job. I guess I'll go be a gate agent for Delta now. No, they're doctors. They're going to go, oh my gosh, the world's going away. My job's not relevant anymore. What am I going to do? Get back to the scope of practice thing, y'all. We need to watch for that, okay? So what's going on with this? We'll stay on the space theme for a minute. This is a black hole, or at least an artist rendition of it. These are the things that you need for AI. This is a little bit over my pay grade. I kind of dabble on the edges of it. I know some of what this is, but I won't embarrass myself talking about that right there. But we're there. We got the stuff necessary. And so AI will affect y'all more than just writing manuscripts, but changing things. And why wouldn't we? Why would we continue to have humans looking at MRIs and CT scans when a computer can instantly give us the diagnosis with huge data sets, saying over the last 50,000 CT scans of sarcomas I looked at, me as a computer say this. I would go, wow, okay, I'll listen to you. So here's the advantages and disadvantages. Of course, a disadvantage is a loss of jobs and a lack of human touch. But if you look on the advantage side, it's pretty strong. And so the advantages of AI in medicine are pretty dynamic, and we need to, once again, to be flexible with it. So the line has already been crossed with all four of these. We're moving ahead. The answer is the value paradigm. So don't be depressed. Don't be scared. Don't be what are we going to do with our lives? How's this all going to work out? It's all about pivoting and all about maintaining the value paradigm. As long as we're doing quality over cost times access, and we're fitting into that certain spot, and we're providing value to the community, we're safe, and our jobs are good, and we'll enjoy them and go from there. And the future looks very good from there. So thank you very much for inviting me down. I really appreciate it. It's been an honor to speak for the Build Along lecture, and thanks.
Oh, yes. Yeah, don't forget your $100. Any questions? Any questions? You can come up to the mic. I think Rajito's got a question. No, he's heading that back. Great talk. I think that one thing I haven't heard a lot about is I think AI is going to impact education. I know Khan Academy is I think trialing basically an AI tutor. So I think there's going to potentially be a huge value of that, and it's going to eventually potentially translate to medical education as well, where you're not just at a computer doing questions, and there's not just adaptive learning, but there's something interactive saying, hey, it looks like you're having trouble with this issue. Can you tell me about that? I don't know. Have you heard anything about that? I mean, I think that's something that we're in a medical education institution here. I see that potentially coming and being a benefit to educators.
Yeah, I think that's a fantastic example of the positive roles of AI. I think in the net, AI is going to be way more beneficial than it is negative. However, like I said, some of the AI is now passing a Turing test, right? And you have computers actually talking to each other, which is a little spooky thinking how far that can go down the rabbit hole. But in terms of the benefits from it, I think there's some substantial amounts of lift that we can do with it.
All right. Well, stay on time. We are. I'm sorry. Question, Dr. Elias.
That was a great talk, very provocative, and appreciate your time and your expertise. And by the way, your service to the Academy and all of us for all those years on the advocacy of the advocacy there and share. A question on the scope of practice. Many of us are aware of the dynamics in chiropractic, physiatry, or plastic surgery, or therapy, there's coaching, all those places. Where do you find, as of today, like in the 20th century, where do you see orthopedics most susceptible or vulnerable to those practices?
Well, that's a great question. Clearly, with foot and ankle is significant because you have other doctors immediately adjacent to us that do a significant amount of those procedures. And in many places, podiatrists are operating on the tibia all the way up to just below the knee. I saw a guy in Atlanta that a podiatrist were doing a Lazarov stuff, limb lengthening up in the tibia. I was like, oh, that's fascinating. I think that's a big issue with it. I think it can come from almost anywhere. And my points are, is I think as technology increases, and I was using radiology as the impetus of that, as as general surgery and vascular surgery lost control of a lot of things to the radiologists, similar things can happen to us. I mean, when you talk about these radiologists that are now out of jobs, they've been looking at x-rays with screws in them for a year. They go, that can't be that hard. I mean, I've seen the knuckle draggers that put those in. I could put the screw in, and then all of a sudden they're putting screws in things. So I think it could be almost anywhere. Sports medicine, anything with high technology is going to be a significant risk for it. But that's an excellent question. I will probably say those two, but I hadn't thought that the whole way through, but I appreciate that.
Thank
All right, great. Well, I guess just a round of applause for Dr. Lundy. Thank you again.